May I now invite Dr. Vijay Kumar, the pulmonologist and intensivist. I recall a fond memory almost going back by 28 years where we did a workshop at Medicity with Servo 900C mechanical ventilator. From 900C to current ventilators, lots of changes have happened. And over to you, Dr. Vijay Kumar.
Thank you. Thank you very much for the nice introduction. Respected chairpersons, my colleagues, um, delegates, ladies and gentlemen. At the outset, I thank Dr. Bhavani Prasad, Dr. Deepak Swarna, and Dr. Srinivas Amvedam for allotting me a very interesting topic. So I also learned a lot while getting ready for the talk. So as far as artificial intelligence is concerned, Google says India is already there. It's being used by a majority of the people in multiple fields, and medical field is no exception. And just to give an example, there is a lot of artificial intelligence in Google, Alexa, and now ChatGPT. And all of us have got these smartphones in our hands. And whenever you want to type something, and the artificial intelligence automatically corrects the spelling. Whatever advances that can made by the artificial intelligence, it cannot match the the nature that has provided us with the respiratory system apparatus, right from the brain to the diaphragm to the extraordinary lungs and all the connections. To some extent, of course, the artificial intelligence can play a role in mimicking almost the normal physiological functions of the respiratory system. And all of us are familiar with the open loop and the closed loop modes, where in the open loop classic modes, the basic modes or the conventional modes, where the machine delivers as per your order. The problem is they don't take any feedback from the patient, and lung dynamics are constantly changing, and settings that we do in the morning become irrelevant towards the night, and especially in the middle of the night. And clinicians have to keep adjusting constantly. So there has to be an intensivist, critical care person, or a clinician, or somebody there to constantly monitor the patient's parameters and also the settings of the machine. So it is labor intensive and time consuming, as against the closed loop, where a small microchip is embedded into the machine, which is carrying an algorithm, um, which is also called the newer modes or the novel modes or the non-conventional modes. Here, the important difference is it receives the feedback from the patient breath by breath and self-adjusts, and all the cycling, the controls, and the limits of the inspiration and expiration, everything is taken over by the microchip from the clinician's responsibilities. So, in other words, artificial intelligence optimizes the therapy as far as the mechanical ventilation is concerned, and there is a continuous monitoring, there is a continuous feedback coming from the patients. As a result, the patient is more comfortable, it reduces the complications, and it can augment, not exactly replace, the expertise of the clinicians so that the clinicians can make more um, learned, knowledgeable decisions which are required for the patient, like maybe the subtyping of subphenotyping of the ARDS and things like that. And as a result, we can get an accurate diagnosis of the patients that we are treating, and it can provide effective treatment strategy. So, what is it for the hospital? What is it for the patient? The morbidity is less. When we use these microchip based algorithms embedded into the ventilators, the mortality is much less. and ultimately the stay of the patient in the ICU and the time that the patient spends on the mechanical ventilator is less. And the ultimate result is there is a major cost cutting of the treatment process. When you look at the ventilators from a distance, you can't really say whether this is artificial intelligence driven machine or the regular machine that we are all using. So, but the real thing is inside where there is a algorithm loaded microchip. This has already percolated into the non-invasive ventilators. We are already using it, and the microchip which is there already inside these non-invasive ventilators has got an auto ST mode. It self-adjusts because it has got an auto inspiratory positive airway pressure, auto expiratory positive airway pressure, and there is what is known as an intelligent volume adjusted pressure support. So you just set the minute volume or set the tidal volume, and the machine automatically calculates the flow, calculates the compliance, resistance, breath by breath, and it is designed to give about 60 mLs of air for every centimeter of water pressure. So as a result, the intelligent breath rate gets adjusted. So it is ideally suited for those patients who are admitted with acute exacerbations of COPD or patients who get into some kind of a complication with ILD. So chronic lung diseases, and also good for home care, both for neuromuscular disorders or kyphoscoliosis and patients who have a chronic lung disease. The algorithms are very complicated and they are all based on the flow, time, and the pressure, and these are automatically embedded. Let us assume, for example, the target expiratory tidal volume is 250 ml, and the measured average pressure support is 4 centimeters of water pressure, and the estimated volume, the tidal volume of expiratory is 220 ml. So the machine calculates that it is less than what is required. So the how much pressure to be added, it calculates by way of this equation, that is 4 by 220 multiplied by 30, and that comes to 0.55 centimeters of water. So the new pressure becomes 4 plus 0.55, that is 4.55. So the next breath is delivered with this pressure so that it can meet the expired tidal volume. Just imagine, this is only one algorithm. Just imagine that there are several algorithms for every aspect of mechanical ventilation, and there you get the artificial intelligence driven mechanical ventilator. There has been a lot of interest across the world. This is a beautiful review article from the UK where the editor talks about there are certain limitations. At the same time, there are some potential solutions for this. They looked at nearly 1,300 studies, but the 95 studies were eventually included for the analysis, and they concluded there are certain gaps in the knowledge, there are certain gaps in the implementation, and it is very important when these artificial intelligence driven ventilators are made available commercially, there has to be a lot of adherence to the standards and code, and also availability of the data across the world uniformly. And another article, is artificial intelligence ready to solve the mechanical ventilation? The conclusion was no, it is still in the infancy. One of the very important things that we need to create algorithms is a lot of data coming from different critical care units. This data comes only when we document. digitize all our patients, all our mechanical ventilator parameters, patient parameters, everything. This goes into the machine learning, and the machine learning creates the algorithms, and algorithms are put in the chips, and that is how you get the artificial intelligence driven ventilators. Are these good enough for weaning? Because there is one of the very tricky issues. There was an article, artificial intelligence system, can it predict weaning? So here they looked at all the available information. They looked at 11 prediction time points during the mechanical ventilation and 11 prediction models, and a few features in the first stage and a few more features in the second stage. And they created a digital dashboard, and they included 7 machine learning algorithms. And they said electronic medical records from the ICUs is very important. And they looked at nearly 3 years of data, and they calculated the area under curve for the optimal model. So then they came to the conclusion, yes, these algorithms, artificial intelligence driven machines, can predict optimal time for weaning and eventual extubation. What about sepsis management? Yes, even there, a lot of studies are being done. And for this, of course, to go forward, we need robust electronic medical record systems, documentation, uh, which is lacking in many of the critical care units, which is being implemented in many of the corporate hospitals. So I think we still have a long way to go. And checklists, only when they are existing, we can we don't miss a certain point. So here is a lecture given by the chief of Artificial Intelligence Society in India. He says that applying artificial intelligence in medical and healthcare has a lot of challenges, unlike in other fields. Coming to mundane things, back in Hyderabad, I have developed an app because most of the senior consultants in pulmonology are all concentrated in the high-end hospitals, super specialty hospitals. So the patients who are 70 years plus, who have multiple comorbidities, who have issues with the travel, who can't go for a review visits, so they want a pulmonologist to come to the house. So this model works on the aggregator model, just like the Ola cabs and the Uber cabs. So the senior consultant sees the patient for the first time, but for the review visit, a junior consultant will go and visit the patient within a 5-kilometer radius. This again is microchip based app where the senior consultant, the junior consultant, the patient, they're all connected on the app. Every documentation, checklist, everything is in place. All that the patient has to do is ask for a home visit. Currently, it is undergoing some beta testing. Eventually, it can be extended to other chronic diseases where day-to-day treatment doesn't change much, like heart failure, connective tissue disorders, diabetes, hypertension, uh, and a few more diseases. So I was reading a book by Bertrand Russell. The title is Has Man a Future? The answer was given by another philosopher, Voltaire, who said, the present is pregnant with future. So we need to adopt artificial intelligence in our day-to-day healthcare systems, because too soon it will be too late, and then we might end up where the dinosaurs ended. Thank you very much.